Hi class, this is Nicole Mollenkoff, and in this tape lecture, I will review drugs to treat Parkinson's disease. The objectives are listed on the slide. They're also listed in your Blackboard module. Please review the pertinent vocabulary terms before proceeding. You can find the definitions in your textbook. So let's begin by discussing Parkinson's disease. So Parkinson's disease is a slowly progressive neurodegenerative disorder that affects more than 1 million Americans. It's second only to Alzheimer's disease as the most common degenerative disease of neurons. It was first described in 1817 as a shaking palsy, and it was the English physician James Parkinson who described this phenomenon, and that is where the disease gets its name. It affects approximately 1% of U.S. adults over 65, which is basically about 1 million Americans, and it usually presents in patients who are between 50 and 80 years old. The cardinal symptoms are tremor, rigidity, postural instability, and slowed movement, but most patients also experience non-motor symptoms as well, such as autonomic disturbances, sleep disturbances, depression, psychosis, and dementia. Unfortunately, there is no cure for motor symptoms or, in fact, no cure for Parkinson's disease. However, drug therapy that we do have available can help patients maintain functional mobility for many years. So essentially, these drugs improve the quality of life. So I'll briefly review the pathophysiology of Parkinson's disease. The motor symptoms that occur in Parkinson's disease result from damage to the substantia nigra, which is part of the extrapyramidal system in the brain. When function here is disrupted, dyskinesias, which are disorders of movement, will occur. The dyskinesias that characterize Parkinson's disease are tremor at rest, rigidity, postural instability, and bradykinesias, as I've already mentioned. In severe Parkinson's disease, the bradykinesias can actually progress to akinesia, which is just a complete absence of movement. Okay, in this figure, what you see is the neurotransmission in a healthy patient. So the top half of the diagram is a normal healthy patient versus functioning in a patient who has Parkinson's disease, which you see depicted in the bottom half of the diagram. This is figure 21.1 from your book. It's on page 177. So feel free to look into that further. But I'll give a brief overview. So what you see here is that dopamine, or DA as it's abbreviated on the slide, is released from neurons that originate in the substantia nigra, which is the green box on the screen, on the left side of the screen. This dopamine inhibits the firing of neurons in the striatum that release GABA, or gamma aminobutyric acid. Now, the striatum, by the way, in this diagram is represented by the light purple box in the center of the figure. So that dopamine that's released is influencing those neurons that release GABA. It's having a negative influence or an inhibitory influence on those neurons that release GABA. Opposing the effects of dopamine are the neurons that release acetylcholine. Acetylcholine is the red line in that diagram. Acetylcholine excites the GABA neurons, causing an increased release of GABA. So therefore, under normal conditions, dopamine is inhibiting the release of GABA and acetylcholine is increasing or causing the release of GABA. And so these two kind of balance the effects of one another. And ultimately, this results in controlled movements for the patient. Now, look at the bottom of the screen. In the bottom of the screen, what you see is in this Parkinson's disease patient is that the neurons that supply dopamine to the striatum are degenerating, and that's represented by that dotted line. So there's a lack of dopamine. There's either a deficiency or in some cases a complete lack of dopamine. And so what that means is that the excitatory effects of acetylcholine go unopposed. And basically, the two neurotransmitters are out of balance. Acetylcholine is causing excitation, or release of GABA, and ultimately that results in disturbed movement. So, bottom line, not enough dopamine. That's going to lead to too much acetylcholine activity, results in too much GABA, which is causing overstimulation of these neurons, which causes muscles to become tense and produce a rigid movement. So years before actually, before functional impairment occurs, patients may experience early symptoms of Parkinson's disease, such as worsening of handwriting, clumsiness, shakiness, a slower gait, and other symptoms like loss of smell or even excessive salivation. The late symptoms are those symptoms that are most associated with Parkinson's disease. So, resting tremor. This is probably the least debilitating symptom, and it's commonly the sole presenting symptom. It involves the hands usually, but it could also involve the jaw or the legs. When it involves the hands, patients actually look like they have a pill or some kind of small spherical object in their hand that they're just rolling around between their thumb and their fingertips. Usually, this movement abates with purposeful movement or sleep. Rigidity is another late symptom that is one of the motor symptoms that's problemsome. Cogwheel rigidity is problemsome, and overall, this rigidity contributes to postural instability, which can be a big issue for Parkinson's patients. Bradykinesia or just slow movement, slow handwriting, slow movement, like large movements like walking. Patients sometimes have a facial masking that they just kind of look like they're not there to some extent. Decreased volume and clarity of speech. These are all related to those changes with bradykinesia. And then finally, postural instability. This is probably the most debilitating symptom. It causes a shuffling gait that's very well known motor symptom that is seen in Parkinson's patients, difficulty starting and stopping steps, and then kind of all of these things together are going to increase the risk of falls in these patients. I do have a video a little further on in the lecture that I'll ask you guys to stop and watch that you'll be able to see what I mean by these different types of movement when you watch that video. And there are also non-motor symptoms. So we're not really going to talk about treatment for the non-motor symptoms. This lecture focuses on treatment for the motor symptoms. But just know that autonomic symptoms can be present. Sleep disturbances, depression, dementia, and even psychosis are symptoms that can be seen in, or conditions or disorders that can be seen in patients with Parkinson's disease. All right, so let's move on to the pharmacology of the drugs. All of the drugs we're going to talk about are used for the motor symptoms. So ideally, treatment for Parkinson's patients would reverse the neuronal damage that we know is occurring, or at least prevent further degeneration of those neurons, and ultimately, of course, that would control symptoms. Unfortunately, we don't currently have treatments that are believed to actually stop further progression or reverse that neuronal damage. The drugs we have really only provide symptom relief. And obviously, also there's no cure presently either. But even with the drugs that we do have that provide symptom relief, like I said, those drugs, there's no evidence currently that those drugs are even delaying disease progression. So the goal of therapy for these patients, kind of in reality, is to provide relief of symptoms. And if we can provide that symptomatic relief, then that will increase the patient's ability to carry out their activities of daily living. So given that this physiology that these patients are experiencing ultimately is based in the fact that they've got too much acetylcholine and not enough dopamine, I think the approach to treatment is probably pretty obvious. Obviously, we would give drugs that can restore that balance between dopamine and acetylcholine. And there are two types of drugs that can accomplish this. There are dopaminergic agents. These are drugs that directly or indirectly activate dopamine receptors. So because of that, they are helping to balance out that discrepancy that exists between the amount of dopamine and the amount of acetylcholine. And then, of course, there are anticholinergic drugs. So, drugs that can block the receptors for acetylcholine. And even though there is more acetylcholine there because of that blockade, the net effect is that there's less acetylcholine. The dopaminergic agents are listed in your book. There are several. We are going to talk about the dopamine replacement agents. These are really the cornerstone of therapy, the dopamine agonists and the COMT inhibitors. And then we'll also talk about centrally acting anticholinergic drugs that are used for Parkinson's. So let's start with the dopamine replacement agents. So our dopamine replacement prototype is carbidopa-levodopa. Brand name is Sinemet or Parcopa. This is a combination drug. The active component is the levodopa. It's been around since the 60s. It is a cornerstone of Parkinson's disease treatment. It's highly effective, but unfortunately, the effects diminish over time. So levodopa was previously available on its own, meaning not in combination with carbidopa. In your book, there's a whole section on levodopa, but just know it's only available in combination with carbidopa. So the mechanism of action for levodopa is that the drug is converted to dopamine by decarboxylase enzymes in the brain, because that's where you need the dopamine. You need the dopamine in the brain, specifically in the substantia nigra, to counterbalance those effects of acetylcholine. So that dopamine actually will act at the dopamine receptors in the striatum. And maybe some of you guys at this point are thinking, well, wait a minute. Dopamine is a drug that's available on the market. Why don't we just give dopamine itself instead of giving levodopa that has to be converted to dopamine? Well, there's a couple reasons. Number one, dopamine has a very short half-life. So because of that, it can only be given by continuous infusion. So obviously, patients with Parkinson's disease are usually in the community, and it would be difficult, maybe even impossible, to provide continuous infusions of dopamine. Number two, dopamine also has not just activity in the brain, but it also has activity in the periphery. And when I say periphery, I mean not the brain. So the other parts of the body, not the brain. And that's actually a big problem because the adverse effects associated with levodopa are those things that occur kind of in the periphery, not as much in the brain, although those are also, some of the activities are also a result of activity in the brain. But it's the peripheral activity that if we can block that, that would be desirable. And that's where carbidopa comes in. Carbidopa is combined with levodopa because carbidopa prevents carboxylases in the periphery from converting levodopa to dopamine before it gets to the brain. So what that allows is more dopamine's actually able to get to the brain and produce its effects. And then there are less of those peripheral side effects. So carbidopa on its own has no therapeutic activity, meaning if you just administer carbidopa by itself, it does nothing to treat Parkinson's disease. It simply breaks down it simply prevents the breakdown of levodopa before it gets to the brain, resulting in more drug actually making it to the brain. That allows us to see fewer side effects, and also it allows us to reduce the actual dose of dopamine that the patients need. And this is just a diagram that kind of illustrates how carbidopa works. This is also from your textbook, so you can take a look at it. But again, on the left side, you see that carbidopa on the left side of the picture, you see no carbidopa. 98% of the dose is lost before it gets to the brain. And in this example, this is nice because the total dose needed is 10 milligrams. To get 10 milligrams of the drug to the brain is 500 milligrams. And so 98% of that is just getting broken down in the periphery and potentially causing side effects. On the right side of the picture, you see carbidopa and levodopa combined. The total dose of levodopa that's needed in that scenario is only 100 milligrams in order to get 10 milligrams to the brain. Some of that levodopa will still get broken down in the periphery, but it's dramatically less than when we use levodopa without the carbidopa. So again, bottom line, Combining carbidopa with levodopa reduces the overall dose that's needed by 75%. This reduces side effects such as cardiovascular side effects, reduces nausea and vomiting, also reduces drug-drug interactions, and so forth. So that is why levodopa is no longer available on the market without carbidopa. So therapeutic use obviously is for Parkinson's disease. This is the most effective drug we have for Parkinson's disease. About 75% of patients will experience at least a 50% reduction in symptoms after starting therapy with carbidopa-levodopa. It is very effective. And so if a patient starts this drug and they don't have symptom reduction, that's pretty indicative that they probably don't have Parkinson's disease. The full response takes months to achieve. You have to educate patients that it's going to take a couple months for them to see full improvement. Long-term therapy with this drug, after about 5 years, symptoms usually fall back to pre-treatment levels. Likely it's just due to worsening of the disease and not necessarily the drug not working anymore. It's used as an initial agent, but it's usually for patients with severe symptoms when the primary objective is to improve motor function, because this drug is very effective at improving motor function. A couple things to be familiar with this drug. There's the wearing off effect, or the on-off phenomenon. This is wearing off is what happens at the end of the dosing interval when the blood levels decrease and symptoms become worse again. Generally, what we do is give the drug more frequently in that scenario so that it doesn't wear off towards the end of the dosing interval. Another phenomenon that's seen in some patients on carbidopa-levodopa is the on-off phenomenon. And this is just an abrupt loss of effect of the drug. It can occur anytime, even when drug levels are thought to be the highest after just maybe just an hour after the dose was given. So it's not related to blood levels. And it's almost like the patient is being turned off. And I'll show you guys a video of kind of what that looks like. Patients can resume activity sometimes minutes later. Sometimes it takes an hour or more for the effects to turn back on, so to speak. So here's a video. You guys can click on this link, pause the tape, click on the link, and watch the video. It's pretty short. It's only a minute or two. But take a look at it, and it shows kind of what patients look like when they're off and what they look like when they're on. It's pretty profound. I think you guys will enjoy watching the video. Okay, so hopefully you found that video informative. So let's talk about the adverse effects with carbidopa and levodopa. Most adverse effects are dose dependent, and this is especially true for older patients who are more sensitive to the drug. Some of the early adverse effects, like nausea, vomiting, and hypotension, sometimes these resolve after a few weeks of treatment. There are things that can be done to minimize these, such as taking the medication with food, titrating the dose up slowly, things like that. CNS effects can also occur, so confusion, hallucinations, depression, these are just some examples of the manifestations of the CNS effects, which again kind of makes sense. The drug is working in the brain, so it's not surprising that there would be some CNS side effects. Involuntary movements is one I wanted to mention. This one might seem odd to you guys because I just said that we're using this drug to eliminate movement problems, but yet using the drug can cause movement problems. And really what it comes down to is there's really a fine balance between the right amount of dopamine and the right amount of acetylcholine. And sometimes we overshoot a little and we have excessive dopamine levels. And so too little, too much, either scenario can result in movement problems. There are also drug-drug interactions that are of concern. Probably the biggest drug-drug interaction that's of concern are patients who are taking first-generation antipsychotics. I won't go into that drug interaction now with Parkinson's disease because this week we also talk about antipsychotics, and so I'll explain that in more detail when we talk about the antipsychotics. The MAOI inhibitors are also drugs that potentially will interact, and it could be could be a serious interaction. We talked about the risk for hypertensive crisis with patients who are on MAOIs, and so um, that risk can be heightened if the patient is also taking levodopa. So some nursing implications. I already mentioned that the drug can be taken with food if the patient's experiencing nausea and vomiting. We do prefer to give it on an empty stomach just because high protein meals can significantly inhibit um, or delay the absorption of this drug. So we do like to give it on an empty stomach if possible, but if the patient has pretty significant nausea and vomiting, you can tell them they can take it with food, but they have to be warned not to take this medication with a high protein meal. Um, and again, if the patient does experience an onset of action that's delayed, then we would want to give it on an empty stomach. You can crush or chew the tablets, the immediate release tablets, and take that with a full glass of water. And if for some reason the patient is experiencing a delay in the onset of action, you would always want to verify if they are taking it with food, what they're eating it with. If it's a high protein meal, that's completely expected. You want to educate your patients on the possibility of the on-off phenomenon so that they know to look out for that, as well as potential dyskinesias like tremor. And if any of these symptoms occur, they should be reported promptly to the provider. Most likely the provider will tweak their medication regimen a little bit. They might decrease the dose, they might add another medication, they might increase the dose of the carbidopa component, they might add another drug, but it's really important for patients to recognize that there are things that we can do about those problems and that they need to discuss them with their provider. Finally, abrupt discontinuation of these medications can be life-threatening. In fact, unfortunately, I hate to mention this, but my uncle actually died as a result of abrupt discontinuation of his carbidopa-levodopa. He was admitted for a GI bleed. He ended up in the ICU. He was intubated. He wasn't able to take any of his extended release medications, and he was on an extended release form of carbidopa-levodopa. He had no Parkinson's drugs for over a week. He was completely unable to move. He was unable to speak. It was pretty profound. As somebody who witnessed this occur, it was pretty profound. These patients will experience a variety of symptoms when their medications are abruptly discontinued, and many of these patients never recover. So I guess my take-home message for you guys is if you come across a medication that is a maintenance medication for a patient and they're not able to take it, maybe because they're intubated, maybe it's an extended release drug and they're unable, you don't want to crush it and flush it through the NG tube, talk with the pharmacy and find out what the other options are. Don't just assume it's okay for them not to get that medication for several days or even a week. All right, so let's move on to the dopamine agonists. Remember, agonists mimic the actions of endogenous neurotransmitters. So in this case, dopamine is our endogenous neurotransmitter, and these drugs are going to mimic the actions of dopamine at the dopamine receptor. So the prototype dopamine agonist is pramipexole or Mirapex. As I mentioned, this drug directly stimulates dopamine receptors. It is used as a first-line agent for patients with Parkinson's disease, but usually for those patients who have mild to moderate motor symptoms. It can delay the need for levodopa. It is considered generally less effective than levodopa, but like I said, it's usually used in those patients who present with mild to moderate symptoms. It's also used for a condition called restless leg syndrome. The adverse effects that it can cause confusion, hallucinations, again, because it's a centrally acting drug, nausea, orthostatic hypotension, cause somnolence. One of the most concerning is the impulse control disorders. And so the lack of impulse control can lead to problems like gambling that's out of control. So that's something to look out for, especially for patients who have a history of those kind of problems. It can also cause sleep attacks. Sleep attacks are when the patient just has an overwhelming sense that they need to fall asleep and it just happens. If they're driving a car, that could be a major safety issue. These drugs do need to have the dose reduced if the patient has renal impairment. And then in terms of nursing implications, patients should be educated to recognize those potential adverse effects and report them to the provider so that they can be dealt with. And then the last dopaminergic agent that we're going to talk about are the COMT inhibitors. So COMT is catechol-O-methyltransferase, and that's an enzyme. It's kind of like decarboxylase. So remember, carbidopa inhibited decarboxylases. The COMT inhibitors inhibit the COMT enzyme. And this is important for patients who are on levodopa carbidopa, because at some point, those decarboxylases that are being inhibited by carbidopa, at some point the carbidopa can stop working as well as it did in the past. And when that occurs, that's when we would add a COMT inhibitor as well. And ultimately what it does by adding a COMT inhibitor is just get more levodopa to the brain. That's really the goal. The COMT inhibitor itself has no action to treat Parkinson's disease. The only thing the COMT inhibitor does is allow more of that levodopa to get to the brain. Once it's in the brain, it's converted into dopamine, and then that dopamine activates receptors in the brain. So I guess the kind of take-home point is that if this drug is prescribed by itself for a patient with Parkinson's, that's always wrong. It's not going to do anything to treat the symptoms. It must be used in combination with carbidopa and levodopa. So some adverse effects, it can cause hallucinations, nausea and vomiting, some dyskinesias. Remember, these patients are already going to be on carbidopa, levodopa, so the enhancement of the amount of levodopa getting to the brain can lead to some of these adverse effects. Some of the drug-drug interactions, so methyldopa, dobutamine, isoproterenol, these are just other drugs that are also metabolized by COMT, and so it could result in the need to reduce the doses of these medications if your patient is on any of these. Nursing implications, as I mentioned, this drug is always administered with carbidopa, levodopa. All right, and the last drug we'll talk about are the centrally acting anticholinergic agents. So benztropine is the prototype, or Cogentin is the brand name. These drugs are considered centrally acting anticholinergic drugs. They block cholinergic receptors in the brain. Now, not all anticholinergics can get into the brain, so we talked about other anticholinergics like atropine, and so not all of those drugs are able to cross into the brain, but benztropine is one of the anticholinergic drugs that can actually get into the brain. These drugs, the goal is to block cholinergic receptors in the brain and to bring the balance of dopamine and acetylcholine back into check, or basically improve that balance between the two. Some of the adverse effects, I don't think any of these will be surprising to you guys. First of all, confusion, hallucinations. It's a centrally acting drug, so it's obvious that those would be potential adverse effects. But then those that I have highlighted and bolded, dry eyes, dry mouth, blurred vision, constipation, urinary retention, you should all recognize those as anticholinergic side effects that occur in the peripheral nervous system. And these drugs can activate block cholinergic receptors in both the peripheral nervous system and the central nervous system. These drugs should be used with caution in patients who have glaucoma. And then, of course, to every extent possible, you want to educate your patients on methods to minimize those anticholinergic adverse effects, because they can be debilitating, especially in elderly patients, which is most likely the population you would be using these drugs in to start with.
So let's move on and discuss Alzheimer's disease. There are only a few drugs available, and the data for effectiveness is sparse. However, these drugs are covered on NCLEX, and you will likely see them in practice, especially in the community setting.
So let's start with the pathophysiology. This is a devastating illness. It's characterized by progressive memory loss, impaired thinking, neuropsychiatric symptoms such as hallucinations, and overall an inability to perform daily tasks. Unfortunately, more than 5 million older Americans have the disease. It's the 6th leading cause of death. Underlying cause is unknown, so we don't really know what causes this disease, but we do know of a variety of factors that probably work in some combination to cause the disease, and you can see them listed here on the slide. The primary risk factor is advanced age, and then in terms of the goal of therapy, the goal of drug therapy specifically, ideally it would be to improve systems and reverse cognitive decline. Unfortunately, the drugs that we do have do little to relieve the symptoms or, more importantly, prevent neuronal loss, because this is a neurodegenerative disease. At best, the drugs we have slow progression of cognition and memory and prolong independent function. And just so you guys know, not all patients respond to these drugs. Approximately 1 in 12 patients who are treated with these drugs are actually expected to respond to therapy, which is unfortunate. So let's talk about the pharmacology for the few drugs that are available to treat this disease. The first class I'll talk about are cholinesterase inhibitors. That term should not be new to you guys. We talked a lot about cholinesterase inhibitors in lesson 3. And you remember in lesson 3 we talked about cholinergic and adrenergic drugs. And I'm going to tell you these drugs are going to come back over and over again throughout this course. So don't expect this to be the last time I say you've learned about this drug in lesson 3. Now we didn't talk specifically about rivastigmine or Exelon, which is the prototype drug used for Parkinson's disease, but we did talk about cholinesterase inhibitors and their general properties, and much of that discussion applies to these drugs. So the mechanism of action prevents the breakdown of acetylcholine, and it does that by inhibiting acetylcholinesterase, which is the enzyme that breaks down acetylcholine. Therapeutic use is for Alzheimer's disease, and specifically in patients with mild to moderate symptoms. This drug is also indicated for dementia that's associated with Parkinson's disease. Adverse effects, you can see a lot of what you might expect from a drug that increases acetylcholine at the receptor site, so nausea, diarrhea, salivation, bronchial secretions, bronchoconstriction, CV effects. Remember, the cholinesterase inhibitors are not specific, so they can activate a variety of acetylcholine receptors. So that's why these side effects or adverse effects are pretty broad. Drug-drug interactions, if the patient is receiving anticholinergics, that would oppose the effects of cholinesterase inhibitors. In terms of nursing implications, so identifying those methods to minimize side effects, because there are quite a few side effects. And one thing I want to point out from a safety perspective, this drug is available orally, but it's also available in a transdermal patch form. We talked a bit about transdermal patches when we talked about clonidine, which is an alpha-2 agonist. And I went in detail about just general issues that are associated with the patch dosage form. For this particular drug, cholinesterase inhibitors are associated with a pretty severe overdose syndrome. And so there are case reports of patients who have received the rivastigmine patch, and unfortunately they've had multiple patches placed on them for a variety of reasons. Maybe they had multiple caregivers and one caregiver put a patch on and forgot to take off the other patch. Maybe they had, maybe they were in a hospital and they got transferred between units. On one unit, they had 1 or 2 patches administered, and when they got to the next unit, it was unclear where those patches were. And in the end, the patient ended up with multiple patches. One case report I'm familiar with is a patient who ultimately had 6 different patches administered or applied to his skin, and that patient ultimately died as a result of that. So, because this drug can be very dangerous in an overdose situation, being very careful with the patch form of this drug, I think, is an important medication safety consideration.
And this is the Dear Doctor letter. And by the way, back in the old days, that is what these safety warning letters were called. Now we call them healthcare professional communications, but you guys still may hear that terminology, Dear Doctor letter. Nevertheless, these are now distributed to a variety of healthcare professionals, including nurses and pharmacists. Essentially, these letters are required by the FDA in some cases, or they may be initiated by the drug company in other cases. And the point is to communicate a relevant safety issue with regards to the medication, as well as potential strategies to prevent that safety issue. So in this letter, it includes critical patient information that should be shared with patients and caregivers to ensure the proper use of transdermal Exelon patch. Now, on the slide, you can see in bold some of the important points that should be shared, so please take a look at those. Additionally, I have a picture of the 4.6 milligram patch just so you can get a feel for what it looks like. But please know there are multiple strengths. You do not need to know the strengths, obviously, but just so you know in practice, there are multiple strengths. And this particular patch, as you can see, contains the dose and how long it should be left on the patient. So this one is 4.6 milligrams, and this patch should be placed on the patient for 24 hours. So essentially, every 24 hours, the patch should be replaced. Also know that not all patches will actually have the name of the patch, the dose of the patch, or the duration the patch should be left on actually printed on the patch. Some other strengths may not have this. Other manufacturers may not have this particular information. It really does depend on the patch. So you have all seen this slide before, but I can tell you this is one of the most important slides that you'll see in this course. So I don't think we could share this one too frequently. You've seen it when we talked about clonidine patches, when we talked about anticholinergic, or I'm sorry, when we talked about cholinergic and adrenergic drugs. You also saw it when we talked about fentanyl patches, when we talked about opioids for the treatment of pain. Bottom line, patch errors are very common. So you absolutely need to know these issues or errors that are associated with transdermal patch administration. I want you guys to be familiar with these so that not only for our exams and for the NCLEX, but also in practice, you can take measures to try to avoid some of these medication errors associated with transdermal patch administration.
Okay, let's move on to the second class of drugs that's used to treat Alzheimer's disease, and that is the NMDA receptor antagonist. There's only one drug in this class, memantine or Namenda. It's a relatively new drug. It's, as I said, an NMDA receptor antagonist, which stands for N-methyl D aspartate. So memantine modulates the effects of glutamate, which is a major excitatory neurotransmitter in the CNS. And that basically plays a huge role in learning and memory. And I think that's about all we'll talk about in terms of the mechanism of action. This drug is used for moderate or severe Alzheimer's disease. It does confer a modest benefit to these patients. It slows decline in function, and in some cases it can improve symptoms. Of note, there's no benefit in patients with mild symptoms. And if you want to see how mild, moderate, and severe symptoms are differentiated, you can look in your book in chapter 22 at table 22.1. Adverse effects, not so bad. Dizziness, confusion, headache, constipation, much, much milder than the side effects that are seen with the cholinesterase inhibitors. Drug-drug interactions, this drug is excreted renally. So if you have urinary alkalinizers, it can prevent renal excretion of this drug, which could be a problem. Individual variation, kind of along the same lines, severe renal impairment will impact how well this drug is removed from the body, and thus this drug will require dose reduction for patients with severe renal impairment. All right, and that's it for Parkinson's disease. If you have questions, please post them to the discussion board. And hopefully you found the lecture useful. Also, you could take a look at your textbook. Be sure to read the required reading, especially the nursing implications at the end of the chapter.